I am Joe Harris, the director of the Global Health Politics Workshop. You are here at our wonderful final session of the fall 2024 semester here at the Party Center for the Study of the Longer Range Future, the fourth edition of the Global Health Politics Workshop. Today, it is my distinct pleasure to introduce Dr. Jenny Trinitapoli. Dr. Jenny Trinitapoli is a professor of sociology at University of Chicago. She is a social demographer by training and has published extensively on the role of religion in AIDS and the AIDS epidemic in sub-Saharan Africa. Her new book, which she'll talk about today, is An Epidemic of Uncertainty, Navigating HIV and Young Adulthood in Malawi. And it examines how uncertainty still haunts the everyday lives of young adults in Malawi in enduring ways in spite of treatment that turned a once fatal illness into HIV into a chronic disease. And I have used this in my classes to teach. It's an extraordinary book, and it is full of figures and fables, which are very wonderful to look at. And I think a tribute to her wonderful training as a demographer. Please help me welcome Dr. Jenny Trinitapoli.
Thanks for the invitation to be here and to share this work. Writing a book is its own challenge and pleasure, but the real pleasure is getting to share it with other people and hoping that it prompts new conversations that outlive like the pages or extend beyond the pages. So I'm looking forward to that. So I'm going to present some excerpts from, as Joe said, the recent book, An Epidemic of Uncertainty. And I'm going to pull pieces from a few different chapters in order to introduce you to the setting and share with you some of the different methodologies and different kinds of data that are used in this argument about uncertainty, emphasizing what I think is the key empirical finding, probably the most important thing I learned in 20 years of research on HIV in Malawi, which is that emphasizing the unknown can bring a unique clarity to what life is actually like amid a generalized epidemic. And this is something that I don't really think has circulated widely enough in the literature. And also, the fact that there are limits to the ways that testing might resolve uncertainty about HIV in people's lives. So these are the things that I'll emphasize in the talk, but there's a lot more in the book that I won't get to. So the research for this book is set in Balaka, Malawi, and here's where Malawi is located. If for those of you who aren't extremely familiar. And Balaka is in the southern district of Malawi. And it's actually, the southern district has a few different characteristics. It has the earliest ages of first marriage in the country of Malawi, about age 18. Earliest ages at first birth, age 19, and also the highest levels of HIV prevalence in all of Malawi. About 14% of adults are living with HIV currently, and also like since about 2007. So I talk about this research as being situated at three intersections, and Balaka is a unique place to situate this research. We have a lot of research on HIV in sub-Saharan Africa that is situated in national capitals, and Balaka is a different kind of place. It is a district capital, but it is a trading town on the road between the commercial capital in the south of the country and the political capital in the central region. And Malawi has one long road that bisects the country running north to south. And there is also a train that runs from Zambia to Mozambique there. And Balaka is situated at this intersection of the road going north to south, which has a lot of trucking transportation, and the railway bisecting the country. And at this intersection is a trading town, a very vibrant trading town, where every day is market day. In the neighboring town in Cheu, market days are Tuesdays and Saturdays. And in Lilongwe to the south, market days are on Thursdays and I think on Mondays. But in Balaka, every day is market day. There's a lot of movement, a lot of coming and going in this growing town that's surrounded by about 100 villages and outside of the community. My collaborators and I initiated a study called Segolo Latanzi, which means healthy futures in Chichewa, which is the most widely spoken language in Malawi. And we situated it in Balaka, and we recruited a sample from about a 7-kilometer radius around the town. So it includes all of the town and also, like I said, about 100 villages outside. We designed the study to be a longitudinal survey of 1,500 young adults, and we intended to interview them over a period of 3 years, following them at 4-month intervals. So this was a total of 9 waves to get the study started. We began by enrolling 1,500 women between the ages of 15 and 25. We also enrolled their male partners, so the husbands, boyfriends, and other men that women were making decisions with in their lives. And we enrolled a small random sample of men the same ages as the women in our study. And I want to say a couple of things about this research design. We'd been studying HIV among young adulthood, and we're specifically interested in the relation in how young adult, how the unique challenges of young adulthood. And in high quality longitudinal sample surveys where the inter-survey period was like about 2 or 3 years apart, we found that most of the things that we were interested in happened in the inter-survey period. So time 1, we were interviewing a 15-year-old girl who was in school, not sexually active, didn't have a boyfriend, wasn't particularly concerned about HIV at all. And 3 years later, at age 18, we met a woman who was not in school, who had a child, who was concerned about or infected with HIV and no longer together with the child's father. In other words, all of the things that we were interested in happened in the inter-survey period. And that is because young adulthood, I describe it as eventful, okay, with an early age at first marriage, an early age at first birth, and also a lot of relationship instability, which has been documented for, a century or more in Malawi in particular. All of the things that we were interested in unfold in a very, very short period of time. So following people at shorter intervals seemed essential for trying to understand HIV risk and family formation in this context. We found that 4-month intervals was essentially the shortest interval that people would tolerate and keep coming back to us without being bored. That's a very scientific, I rewrote it in a much more convincing and scientific way in the proposal, but fundamentally, it's how often can we see people to understand how quickly the changes in their lives are really occurring and try to understand something about causal order. I will also say that when we originally designed this project, we had designed it to enroll 1,500 women and also include the male partners to understand how women were making decisions in dyads, in relationships. And so it was really the couple that was at the center of our analyses. And the way that we did this is we interviewed women, we asked them about their relationships, and we gave them tokens that they could give to husbands, boyfriends, and other men in their lives to enroll in the study. What we quickly realized that I hadn't realized when I was writing the proposal is that everyone in the community would soon realize that all the men coming to the research center to participate in these interviews were partners, right? And so we enrolled a random sample of 600 men, the same ages as the woman, for 2 reasons. One was because the random sample could allow us to understand how different the male partners were from a random sample of men of the same age. As we would expect, they had higher employment rates, they were older, and they had some other characteristics that make them different from a random sample of people. But we only understood that because we had the 600 men. And the second was for cover, right? Or how did people get into the Segola-Atanzi study? People are randomly selected through scientific methods that work much like a lottery, and also through referrals through their relationships. So the Segola-Atanzi project was designed to run during these 3 years, and we had a staff of about 30 interviewers, 25 data and a team of about 25 data entry people. We had a gardener on staff because we really wanted the research center to be like a pleasant and nice place where people wanted to hang out. We also had cleaner, and we had guards who were part of our data security protocols. We had a granny who helped take care of the many babies coming in and out of the research center. This is extremely important if you are running a study on young adulthood and fertility, to have some help with the little ones who are coming in and out of the research center. So the study ended up having a pretty big imprint in the community, being located close to the main market, and also being a place of employment for about 60 people at any given point in time. The study was renewed twice, and later in the talk, I'll give a little bit more explanation of the justifications for why we were renewed to extend the study in 2015, and then again conduct another follow-up in 2019. But overall, we have a decade of observations from the women and the men in this study from 2009 to 2019. So that gives you a sense of this actual intersection where we are and where the where Segola-Atanzi sits. The second intersection I talk about is a substantive intersection, and that's about the relationship between HIV and fertility. Here, we're thinking about the fact that what I'm showing here from the demographic and health surveys is HIV prevalence by age over 3 periods of time, and also the age-specific fertility rates. And you can see that HIV prevalence rises very sharply during young adulthood, right? The HIV prevalence is very low for 15 to 19-year-olds, but it escalates very, very sharply for the ages 20 to 24, 25 to 29. And so this is why we focused on this period of the life course. Now, when we think about why HIV and fertility are related to one another, it's important to think about the way that the global community has approached HIV prevention in this part of the world. Specifically in Anglophone sub-Saharan Africa, the ABC campaign, abstain from sex, be faithful to one partner, and use condoms to prevent HIV, it completely saturates sub-Saharan Africa. You will see it on billboards, you will see it on t-shirts, you will hear about it in radio programs. But as you may know, during the period of family formation, abstinence is not realistic for people, specifically when they want to be having children and forming families. Condom use is not conducive to conception, right? And being faithful to one partner is not something that is completely within a person's own control, right? In a relationship. So ABC has a unique, so the approach to HIV prevention, it creates a set of dilemmas for young adults who want children but are also worried about infection from a partner at this period of life. And it's no surprise that we see the highest number of new infections during the years of peak fertility, right? So the questions that we're asking in this study is, how do young adults negotiate relationship, sex, and childbearing in the context of a severe HIV epidemic? So the third intersection I describe as an intellectual one, and demographers tend to be more focused on quantitative modes of research, focused on estimation. And in contrast, within sociology, there are other traditions that are much more focused on ethnographic and types of data, and also theoretical insights. And what I've tried to do in this research is introduce the idea of population chatter. What I mean by population chatter is the way that ordinary people perceive how they perceive, narrate, and debate and respond to the demographic phenomena going on around them. This includes patterns of family formation, marriage, and divorce, also HIV infections, associated morbidity that is visible to people, and also mortality. And my thinking in this is that young people in Malawi do not talk about demographic phenomena the same way that academic demographers do, but they are aware of these things and they discuss them in ways that matter to their own life. So here, the idea is to kind of narrow the parameters of what we're focusing on instead of using quantitative tools to look at all kinds of dimensions of life. It's trying to use a combination of quantitative and estimation focused tools that demographers are known for, alongside a more theoretically robust and ethnographic approach, but focusing on the core concepts of demography, specifically fertility, mortality, morbidity, family formation, and divorce, and to keep the topics a little bit narrow, but be more methodologically ambidextrous, let's say. So everybody okay so far? All right. So what I want to share next is an example of population chatter from our study. And this is the vignette that I used to open the book. I'm going to read it, which is a little bit unusual for quantitative researchers talk. But the context of this story is we're in August 2019 during the last round of data collection. And one of the researchers, Caroline, who has worked with me and with the project from the very beginning, was like choking on her own laughter and wiping tears and was trying to get my attention. I was working in the data room, waving me over to talk to her. Over the course of a decade, our longitudinal study of relationships, childbearing, contraception, and HIV risk only occasionally produced such comedy. Jenny, this respondent is clever, Caroline said. She is open about her life, and wow, she is good at telling stories. We're just enjoying talking with one another, but I need some paper because my notes will not fit well in this small line for other reason, and we need your help deciding what to put down for her marital status. Now, marital status is not among the items survey researchers typically consider a complex construct. The choices are straightforward: never married, currently married, cohabiting, divorced, separated, or widowed. And this is how we list it on the survey, in our survey, just as most sample surveys do. However, Patuma's marriage was indeed an it's complicated situation, and her vivid narration took me on a journey from uncertainty to certainty and back again. So I'll read this from Patuma's perspective. My husband and I have 3 children together. The first one, that was unplanned. I was only 15, but we stayed together and got married 2 years after the first one was born. All of my children are with this man, and all of his children are with me. We've been happy together since 2006, but as of late, I have been doubting him. For example, one night he didn't come home, which is something he had never done before. And then, about a week later, another night. Maybe if he was a security guard, but my husband is a welder, and welders don't work at night. I talked with him about it. I told him about my suspicions. I even called our Kozwe. These are the traditional marriage mediators. But they didn't help. They just said, well, after all, he is a man, and that's how men sometimes behave. You just have to accept it. But there's no need for you to end the marriage over some doubts. But I was not ready to accept that, not with this disease. My mother died from it when I was 1 year old. My father had already run away to Nsanje district. I was raised by my granny, but since I myself am an orphan, my own children don't have grandparents who could raise them. From there, I started hearing rumors about his behavior, hearing that he had another partner. My friend called me and told me she was standing at Mavuto Lodge watching my husband enter that area with a woman. And she advised me, she said to me, Patuma, you have to catch him red-handed. So I started paying very close attention to where he was going and when, even following him from time to time. I usually just stay home farming while he goes to work in town, but I started moving around to find out more about what he's really doing. Last week, I followed him to a certain place near where my friend had seen him. Indeed, he was meeting a woman there. The two of them went into the bush, where sometimes people go to have sex. So I was right to have these doubts. Still, I didn't say anything to him. I just went home. The next day, I went to the bush in the late afternoon and I hid there for hours. I was so scared. I was scared of the bush buffalo trampling me. I was scared of being bitten by snakes, and I was cold. After waiting for hours, probably 6 hours, I went home in the dark, shivering. I was a mess. My husband was there at home, and I told him I had been visiting our friend who was at the hospital. I paid attention to how he was behaving, and I decided to go again to the bush. I hid on the ground in those grasses a bit far away from the road, and I had not eaten anything since the morning, but I was hungry and I was worried about snakes. But I had dressed more warmly the second time. I had prepared well to hide in the bush, like an animal or a mad person. Then I started thinking, what am I doing? I'm going to get killed, trampled by bush buffalo, or murdered by another mad person hiding in the bush. Just then, my husband appeared with that same woman. The woman was carrying a plastic bag with something he had given her. I stayed quiet, and they took off their clothes and started doing sex. I moved closer, and when I saw that they were very busy, I crept near to pick up the trousers of my husband and a wrapper of that lady, and I crept to another spot to grab the bag. I wasn't close enough to get their underpants. I left those and I snuck away, and I returned to my home very late in the dark, and I was not happy, but I was proud of myself. In the bag, he had brought her 4 eggs, some tomatoes, and a small bottle of cooking oil. In the morning, I did my chores as usual. I washed his trousers and that wrapper along with all the other clothes. I hung everything out to dry. When the laundry had dried, I took down my own clothes and the children's clothes, but I left his trousers and that wrapper hanging outside the house. Later in the day, my husband came home. I welcomed him and asked if he would like to eat, and he said that he would. So I brought out that bag he had given to that lady, and I slowly took out the tomatoes and the eggs to start preparing the food. We were sitting in the front of the house. I got my knife and I started chopping the tomatoes, and I was looking at him but staying quiet. Then I asked him, please bring me some more charcoal for the stove so I can fry these eggs in this oil. He went around to where we keep the charcoal, and from there, he could see his trousers and her wrapper hanging on our clothesline. So now we are discussing whether to end the relationship. We are still staying in the house together. Naturally, my husband has called the marriage mediators to come to the house. They will be here either tomorrow or the next day. Today, your project has asked me a lot of questions, including about my marital status, but the truth is that today I do not know whether I am married or whether this marriage has ended. Now, don't know answers in survey research are typically regarded as a problem, a research anomaly, a violation of the assumptions of perfect information, a source of missing data. Frankly, it's a nuisance for analysts. But consider instead from the story that don't know answers are a portal for understanding the social world more deeply, and that they can be studied in an empirical framework. Patuma's difficulty answering a supposedly straightforward question about the basic demographic trait speaks volumes about the force of uncertainty in everyday life. For the purpose of completing our questionnaire, we categorized her as married, and her answers to other adjacent questions, the suspicion of other partners, a question mark on whether the marriage will still be intact a year from now, a recent call to the marriage mediators, all these things would indicate to analysts concerned with relationship quality that this marriage is in a fragile state. But this uncertain relationship is linked to another salient uncertainty, which is a question about her HIV status. Patuma had been tested for HIV 3 times in the past year, twice during antenatal care, and once when she started suspecting her husband of having other partners. She indicated in our survey that she has friends who are HIV positive and doing well thanks to antiretroviral therapy. If she tested positive, she believes that she would get the treatment that she needed to live a long life, and she does not know her HIV status. Even on receiving a negative result from the testing services offered within our study's protocol, Patuma still articulated doubts about her HIV status. Like thousands of other women in Balaka, she is uncertain. In fact, she is navigating an epidemic of uncertainty. Now, when I call HIV an epidemic of uncertainty, I want to emphasize that I'm referring to an epidemic that has been ongoing for more than 30 years in Malawi, the setting of the study. HIV is an established disease, and the uncertainty that accompanies it cannot be attributed to novelty, things that, with more support from the scientific community in time, will become known in due course. The AIDS-related uncertainty that characterizes Balaka has become a stable fixture of social life. And so I want to take a couple of minutes to think about the metrics that we tend to use in studying HIV and map it onto Patuma's experience and the timing of the TLT study. HIV began as was very mysterious when it was first discovered, and HIV related deaths, which are visible in a community, even though prevalence is not visible, right? People can one cannot know who is HIV positive and who is not based on appearance, and people tend to get sick only 8 to 10 years after they have been infected, right? So prevalence and incidence are not things that are visible to the eye in a community. However, HIV-related mortality is, and that's what we see rising there. And behavioral changes are evident starting quite early in the epidemic, really, as soon as people began to understand that this was a sexually transmitted disease that could be prevented. Behavior change was swift. New infections started declining, but HIV-related mortality was still increasing because of the infections that had preceded this, okay? Then antiretrovirals, HIV mortality began to decline, as you see in this graph, many years before antiretrovirals became available, and that's due to behavior change. But antiretrovirals have and are allowing people to live healthy lives, and the rollout of antiretrovirals for everyone, also most specifically for HIV-positive pregnant women, began in 2009 and has been wildly successful with upwards of 90% of the people who need them receiving antiretrovirals today. So when we think about Patuma's life in relationship to this, and Patuma as a stand-in for everyone in the TLT study, our cohort was born at the time that the first HIV cases were registered. And this Lexis diagram shows us their ages and the time passing on the x-axis, their ages on the y-axis, and these lines, so the diagonal line you can think about as lifelines of the people in the cohort, and the shading represents when we are observing them. And then the lines that I've dropped, these vertical lines, tell us something about major changes in the society. So when the first cases of HIV were registered, UPE stands for Universal Primary Education. And I get a lot of questions about education and knowledge about HIV in this setting. And while it is true that the quality of education in Malawi may not be at the quality that we wish it were, it may not be the same quality that it is in many other parts of the world, universal primary education became policy when this cohort was very young. Almost all of them have been to school, and school is a place where people learn, among many other things, about HIV. Okay, and so knowledge about HIV in this cohort is very high, both through people's experience and the knowledge they get in their networks and their communities, and formally through schooling. This cohort was, they were young children and adolescents during the years of peak HIV-related mortality. They were going to sometimes between 3 and 6 funerals every week during those years when HIV was at its highest. So this is what characterized the adolescence of this cohort. Nevirapine to prevent mother-to-child transmission and antiretrovirals became available in the community between 2006 and 2008, first in first in city centers and much later in rural areas and in district capitals. But this cohort has experienced, and Patuma in particular, she has witnessed the introduction and the success of these drugs in the community. Option B plus I mentioned this as a major policy change here because it was one of the rationales that allowed us to continue the study. Option B plus was a way of distributing was pioneered in Malawi, and this was a policy that gave HIV positive pregnant women antiretrovirals regardless of their underlying health status instantly and kept them on antiretrovirals for life. And that was considered a stopgap policy in order to strengthen the rollout of antiretrovirals before there was enough supply to achieve universal test and treat, which was implemented in 2017, right before we continued our study in 2019. So these two policy changes about treatment were really important to extending our study in this cohort, has been part of all of these very positive changes. But I want to say that even though universal test and treat may not be perfect in practice, what it means is that if you are diagnosed with HIV and BLCA, you will be referred to care and you will start antiretrovirals that very same day. Supplies are not always what we wish they were. We would want someone to get a 30-day supply or a 90-day supply when there are problems, when there are problems with the supply, people will get shorter, we'll get a smaller quantity. You'll get seven days or something like that. But fundamentally, what's important to know about universal test and treat is that upon diagnosis, people are getting life-saving drugs immediately. All right. So Patuma's a very interesting, fascinating, a very interesting person and one of the most fascinating people I've ever met in my life. Her description of uncertainty in her story is very memorable one, but I want to make this argument that AIDS-related uncertainty, the kind of uncertainty about her HIV status that she articulates, is measurable, that it's pervasive in this community, that it's impervious to biomedical solutions, meaning that it can't be solved just by testing, that it's persistent over time, and that it's consequential. It matters in people's lives. So I'm going to go through these pieces of this argument about HIV status uncertainty in the coming slides. Measurable. All right. So a lot of people have asked questions, Likert scale questions such as this, and gotten huge proportions of non-response, such as don't know and refusals in when asked about the likelihood that they are infected right now. The way that we approached this question in our survey was to ask our respondents about the likelihood that they are infected with HIV right now, that they would become infected in the coming year, and they will become infected in their lifetime. We asked about HIV. We also asked about a lot of other things going on in their lives. And instead of asking them to answer the questions with words, we gave them a pile of 10 beans in a little cup. And so they were to put the number of beans into the cup to indicate the likelihood that this thing is true, okay? So 10 beans means certain yes, 0 beans means certain no, 5 beans somewhere in between, and other kinds of expressions of uncertainty are articulated using these beans in a probabilistic way. And so our respondents answered these questions with beans in the cup. And what you can see here is on the first day of their first interviews, this is the cross-sectional data from 2009 when we first began the study, the modal answer, 60% of our respondents put 0 beans. They were confident that they did not have HIV. But when asked to think about the coming year, that certainty of being HIV negative dropped by 20 percentage points, okay? And when you're asked about their lifetime, 50-50, 5 beans became the modal answer. And this is probably like the most important distribution of the study and of the book. And but for analyzing uncertainty in terms of how we're thinking about it theoretically, I measure uncertainty in a couple of different ways. The first is thinking about acute uncertainty. So taking that distribution, pulling it up by its middle and saying, okay, people who give answers 4, 5, and 6, they really do not know what their HIV status is. No answer could really be surprising to them. People who put 0 are insulated. People who put 10 have a confirmed or a known infection. Another way of thinking about it would be that any expression of uncertainty, anything between 1 and 9 beans, is a different way of thinking about uncertainty. So one of the things I really like about this approach to measurement is that it gives the analyst flexibility in thinking about uncertainty in a couple of different ways and comparing it to vulnerability, for example, which would be a high probability of infection. So when I say that HIV uncertainty is pervasive, I want to show you what it looks like, new HIV infections in our study, the first 3 years of the study. New HIV infections, both perceived through the self-reports of 10 beans and new infections through an HIV biomarker that we give. This is what it looks like over the period of over the 3 years. But when we ask about uncertainty, right, it's people aren't giving this, they're changing their answers when we see them at these different points in time. More than half of our respondents express acute uncertainty at some point in the first 3 years of our study. And interestingly, there's no difference here for men and women, even though there are differences in actual HIV prevalence. Obviously, if we expand the definition of uncertainty to any uncertainty, we're going to see a steeper hazard curve here. And indeed, we do see that. Fundamentally, when we're looking at uncertainty over these 3 years, over the course of the lifetime, statistically speaking, almost nobody survives the period without experiencing uncertainty. There are fewer than 30 people who don't express any uncertainty with beans over the period. So that is my argument that it's pervasive. Now, the other thing that I said was that I think it's impervious to biomedical solutions. And in Patuma's story, I mentioned the fact that she had been tested 3 times in the past year, right? And still gave don't know answers about her HIV status. And the idea that one can know their status by getting tested is another prevalent message from the international community, and promoted in a lot of settings, and for very good reasons. When people are diagnosed, as I said, especially under universal test and treat, they can get life-saving drugs that same day, right? It is really the diagnosis to treatment pipeline is really important. But in this argument about uncertainty, I've heard the question a lot of times, just get tested, then you'll know your status and the uncertainty will be reduced, right? Can't we just scale up testing? And we have tools for dealing with this, which is that we randomized within our study when people were tested during the first 3 years. And some were randomly assigned to a group in which they were offered HIV testing every time we saw them. Others were tested only at the end, and some were tested in the middle of the study and again at the end. So we understand, we asked them questions about if they were tested at antenatal care or outside of our study, but we have this experimental approach to testing, or to how, and which includes people getting information about their results through by a trained counselor. We would think that testing should abate uncertainty and that there should be differences in these groups, right? People who were tested every 4 months and receive results would be less uncertain than those who are only tested once at the end. And I didn't even put confidence intervals on these graphs because there's absolutely no difference between among these experimental conditions and the same is true when we expand when we expand the definition of uncertainty. And Patuma's story tells us a lot about why, right? It's because HIV uncertainty is tied to relationships, and it's tied to many other things that are outside of a person's own control. Okay. Despite the fact that HIV treatment was hard to get in 2009 when we began the study and has become universal, despite the fact that HIV-related mortality has really, really declined over the course of the study, HIV-related uncertainty is persistent over the period of 10 years. And this is something that I did not expect. It's something that I find very fascinating as a fact. But in this way, I think that it represents a kind of aggregate that has a force similar to other population related processes and characteristics that we see in the social world, such as, you know, 1 year to the next, the birth rate tends to be fairly stable in most societies, right? It's different people having children, it's different pregnancies, but there is a stability to birth rates. There is a stability to death rates. And though I wouldn't expect you to see the details on all of these, what you can notice is that from 2011, 2015, 2019, reading these distributions vertically, you can see that they don't change much, right? They don't change much. There's a stickiness to the uncertainty that's present in the population at a given point in time, even though the particular people experiencing uncertainty are changing, and even though the epidemic is changing in terms of being less deadly, in terms of there being more treatment, and in terms of there being less mother-to-child transmission in particular. And so this is the evidence that I'd like to offer about the persistence. Now, finally, I'd like to say that I think that this kind of uncertainty around HIV is consequential. And I want to contrast the uncertainty, the probability distribution way of thinking about uncertainty to let's say, a binary biomedical way of thinking about HIV status. And if you're thinking about treatment, it does make sense to sort the population according to serostatus, right? Including according to who has HIV and who does not. If we look at self-rated health, sick days, life satisfaction, and depression, these are outcomes I chose because they are widely used in the literature. We see, according to serostatus, things that we would expect, right? Lower levels of self-rated health, more days were missed of school or work, and slightly higher levels of depression among those who are living with HIV compared to those who are not. But what I want to say is that recall, 40% at least of the population is expressing uncertainty at any given point in time, right? And that when we look at the patterns, the association between health and uncertainty, we see that both the tipping point and the direction of these relationships at this uncertain middle, or this uncertain 40%, is really consequential for the experience of self-rated health, which starts to decline at the expression of at about 3 beans, right? Depression, on the other hand, starts to tick up. We see more evidence of expression only at the first expression of uncertainty, right? It starts to rise at just 1 bean. Life satisfaction I use the vertical line to show the statistically significant threshold of change on the distribution. Life satisfaction really dips at around 5 beans. And sick days is the only thing that looks quasi-linear of the 4 outcomes, right? And this is to say that it's not only the virus itself that has consequences in a community, but that this uncertainty that people are living with does have real consequences, at measurable consequences, for example, for their health. So this, back to Patuma's story, HIV-related uncertainty is layered with other kinds of uncertainty, specifically relationship uncertainty. And this is something that I explore in 2 chapters in the book. For example, this is a very unusual use of what mortality models or what mortality methods were designed for. But this is looking, when Patuma starts suspecting her husband of being with someone else because he's not coming home. We measured among our entire sample, knowing or suspecting that a partner has other partners. And this question about hearing gossip about a partner is a more stringent measure. So this would be picked up, for example, by the fact that, her friend calls her and says, like, I'm seeing him at this place, you've got to be attentive. So hearing gossip about your partner is another measure. It's important to point out here that men are also experiencing relationship uncertainty. Women experience it more severely in our study, and that's consistent with the qualitative research. But men also have experiences of relationship uncertainty, and specifically relationships and HIV are really closely related. And again, this is another kind of uncertainty that I think we shouldn't leave to the things that can't be known and the things that we can't study well, but that we can do more and better with creative methods to study well empirically. So the idea of there being of uncertainty demography, as I explained it in this book, is two things. The first is using demographic tools to study uncertainty and to try to measure it in the world and look at its consequences. And the second is thinking about uncertainty as a phenomenon as it relates to demographic phenomena, right? To births and reproductive realm, to health and mortality, and then also to relationships. And that means the formation of relationships, but also the dissolution of relationships, specifically relationships that might be putting a person at risk, right, of HIV. And that's how I see these different themes, AIDS-related uncertainty, of being layered with these other kinds of uncertainties, which are also explored in the book. I want to close with an attempt to say that, or I want to close with the plea that I think that uncertainty is really important, not just because it's something that's very, very interesting to think about and something that we can and enjoy studying, but because I think we will misunderstand many things and get them wrong if we're leaving out uncertainty, right? If we're leaving out people's experiences of uncertainty and presuming instead that the condition is not present, specifically when uncertainty might characterize large numbers of people. But even when it doesn't, I think that not paying attention to it and not putting it not giving it its proper due in social science research leaves us prone to making medium and large mistakes in our estimates and in our interpretations. So with that, I'm going to thank you for your kind attention and take questions.